I'm Kai Blenov. I'm professor in clinical neurochemistry at the Gothenburg University. I'm also senior physician at the clinical neurochemistry lab, which is a clinical lab where we analyze CSF and blood samples from patients. AD pathology consists of three major parts. One is plaques. They are composed of a small peptide, aggregated beta amyloid. Then we have tangles or neurofibrillary tangles. They are composed of hyperphosphorylated tau. And this is believed to lead to neurodegeneration and also degeneration of the synapses in the neurons. That's the typical AD pathology, but in elderly people with dementia, they often have multiple pathologies. So not only plaques and tangles and neurodegeneration, but quite substantial proportion of them also have TDP-43 pathology, Lewy bodies composed of alpha-synuclein aggregates, and not the least cerebrovascular disease. One focus we have is Alzheimer's disease, where we work on biomarkers, meaning CSF, and also today blood tests for different mechanisms in Alzheimer's disease. And then you of course have to ask yourself, why do we need biomarkers for Alzheimer's disease? And one reason is for diagnostics, of course, because Alzheimer's is very difficult to identify clinically. So the symptoms are very vague and they appear slowly. And it's hard for clinicians to say that the patient has Alzheimer's disease or whether he or she has some other disease, either a neurodegenerative disease or even depression or secondary causes for this type of symptoms, such as hematomas or even brain tumors. Then another implication for biomarkers is in clinical trials, because to identify a minor effect of a drug, then you need a very pure and also early patient group that you study, and there you need biomarkers for inclusion, meaning to include the correct population in the clinical study. Then we need biomarkers in the trial, and that's for two different reasons. So one is for target engagement, and then I refer to if you develop a drug that you evaluate in cell culture studies or even in animal experiments, then you need to validate that this drug really hits the target also in men. And one example is BACE inhibitor. So BACE inhibitors, that's a class of drugs that inhibit BACE, which is the same as beta secretase, the first enzyme cleaving APP in the generation of A-beta. And there has been a number of phase 1 studies to show that BACE inhibitors really lowers A-beta production in the brain, that's in animals of course, in the brain, and also in cerebrospinal fluid and plasma, so that we can be certain that this class of drugs hits the target. Then if you, for example, go for anti-amyloid drugs, then it's also good to have evidence of what we call downstream effects, and especially on neurodegeneration. So if you give an anti-A-beta drug, it's a good indication that the drug will really work if you have lowering of neurodegeneration, and that you can measure using biomarkers for neuronal proteins in either cerebrospinal fluid or blood. Another implication is, of course, in research studies. This could be clinical studies on the pathogenesis of disease. It could be genetic studies where you search for new risk genes for Alzheimer's disease, but also in epidemiological studies where you look for risk factors for AD. And a new approach is approach is to evaluate these risk factors and risk genes in populations where you have biomarker data, so that you can say whether a certain factor is a risk for amyloid pathology or tau pathology or neurodegeneration or just old age dementia. That is important to understand the disease. Recently there has been great technical developments, and this is on blood biomarkers, and this is based on new techniques which we call ultra-sensitive assays, where you can measure really minute amounts of a protein in blood samples, meaning serum or plasma samples. And this has enabled us to measure more or less all of these AD biomarkers, A-beta, tau, neurofilament light, and also phospho-tau in plasma samples. And there's a lot of work to be done still, especially for plasma biomarkers, but they look promising, and my thinking is that they can be used in the future as screening tools, maybe in primary care, when a patient comes with memory complaints or other cognitive symptoms, that the primary care physician can take a blood test and get the screening tool for this type of pathologies, and based on the result either send the patient back home or to the specialist clinic for a more detailed evaluation. One thing is that I think it's important to have tools to monitor different aspects of a pathophysiology in Alzheimer's disease and other brain disorders. And one important aspect of AD is synaptic dysfunction and degeneration. And it's well known that there are a number of synapse-specific proteins in the brain that regulates the neurotransmitter release and the synaptic function. And one example of such a protein is neurogranin, and we have a whole set of other proteins, for example SNAP25 and synaptotagmin and many more. And many of these are measurable in CSF, and we already have assays to measure them. And in AD it has been shown that, for example, neurogranin, if we take that as an example, the level in CSF is clearly increased. And it's also been shown that the higher levels will predict the rate of future cognitive decline. And that's maybe logical, since we know that synapses, they are the functional unit for communications between neurons in the brain. So if you have more severe neuronal dysfunction or degeneration, that will predict also the rate of cognitive change in Alzheimer's disease. Interestingly, also, this protein neurogranin seems to be specific for Alzheimer's disease. So very high levels of neurogranin is found in AD, but not in quite a number of other disorders, for example, frontotemporal dementia or Lewy body dementia. We don't know the reason for that today, but it may be related to the specific function of neurogranin. It's involved in memory formation and also in long-term potentiation in neuron, and maybe that's in some way related to why the increase in CSF seems to be specific for Alzheimer's disease. So which biomarkers we have today? That is, to start with, A-beta, and there we measure the 42 amino acid form, A-beta 42. That's also the form that is deposited in the plaques in the brain. So in cerebrospinal fluid you see a decrease in A-beta 42, and especially if you make a ratio to 40, which is the most abundant A-beta peptide, you see a marked decrease in the 42 to 40 ratio. And today we can measure A-beta 42 and 40 also in plasma, and you see the same type of change, but the change is less pronounced, and there's a larger overlap between patients and controls. So if we have a CSF test ready for use in the clinic, we need to work more on the blood test before We can use them in trials or in the clinic, I think, and especially to understand which proportion of A-beta that comes from the brain and how much actually comes from peripheral organs or, for example, from the platelets in the blood. We also have another test, that's phosphorylated tau. It's phosphorylated tau at position 181, and that has been possible to measure in cerebrospinal fluid for quite a number of years. And there's a clear increase in phospho-tau in Alzheimer's disease, in CSF. And that actually seems quite specific for Alzheimer's disease. You don't see it in other tauopathies or in other neurodegenerative diseases. But today there are also assays on the way to measure phospho-tau 181 in blood, and they look very promising. So there's a clear increase in plasma, and the good thing is that there is a tight correlation between plasma and CSF, meaning that most likely this assay measures brain pathophysiology even in blood samples. So that's a promising new blood test for AD.